Please welcome Executive Vice President and CMO of CVS Health, Dr. Troy Brennan.
So I'm going to talk a little bit about retail health, what we kind of call retail population health management, give you some idea of kind of how we're thinking about the future from the point of view of CVS Health in the next 20 minutes or so. So I like to look at a lot of different sort of statistics, and I'm sure that many of you do as well, but this one sort of really caught my eye, and it's a little bit difficult to sort of understand, but what it says is sort of where our healthcare system is headed. And what it shows is the percentage of people whose liquid assets are less than the deductible they have associated with their healthcare. And if you concentrate just on the middle and just on the gray lines, which is a high range, high deductible plan, you can see that people in less than 150% and 150 to 40% have 60% of them have less assets than they do their entire deductible, which means that they can't afford it if they get sick. And this is just an example of sort of how healthcare is kind of thinning out. And if we don't do something about the cost of healthcare, come up with some new ideas, that we're going to be in serious trouble in this country. And so that's kind of what we're aiming for, which is how to sort of improve healthcare, and by improving healthcare, reduce overall healthcare costs. So this is how we sort of see ourselves entering population health management. If I let you with sort of three major lessons, I would say one is that we're going to create a new chassis for population health management. We want to sort of rethink what happens with population health management. The second thing is we want to take a lot of data that's available, especially digital information, and develop insights from that using sort of algorithmic analysis of that information to be able to combine that with the intimacy of healthcare relationships, because we think we're really good at healthcare relationships. Our nurse practitioners and our pharmacists are very good at that. So this digital intelligence plus a human touch is what we're going to use to bring about better levels of engagement, and as a result of that, do things that have been promised in population health management and disease management in the past, but really have not occurred. So let me see if I can put some meat on the bones associated with that, because we want to be relatively sort of specific about what we're trying to do. This is a sort of old model, and certainly something that I in my career and many of you in your careers have sort of dealt with in the past, which is that you're on the telephone trying to call people at home. And for most of you, it's going to be you're calling in on a landline that nobody's answering, and you can't get a hold of these people. And when you do get a hold of them, you really can't do that much about their health care. So what we're trying to do is change that. Keep the patient in the middle of it, and keep the nurse care manager, because we think that's an important aspect of what we and others in healthcare should be doing. But we'll be adding to that the assets that we bring to bear from our retail setting, basically a coordinator, a healthcare coordinator, a minute clinic nurse, and a pharmacist. And we'll be taking advantage of the fact that nurses and pharmacists are sort of the most trusted people in healthcare, and that lots of people consult them for their health care. And we'll also be taking advantage of the fact that a lot of people need some concierge service, some understanding of their benefits, and some advice about sort of where to go to. And then on the other hand, we're keeping the patient's PCP in this picture. We like to think about what we're doing as something that's related to public health, to preventive medicine, to basically low-level primary care, and we're integrating with the primary care providers in this effort. We're trying to sort of maintain the medical home and maintain the accountable care organization. So we've got to keep the PCP on the same page with us no matter what we do. So how do we go about that? We've got basically three targets that we're looking at in 4 tools. So that simplifies things to a great extent. And the targets are 5 common chronic diseases, the fragile patients, that 4 to 5 to 6% that's representing 60 to 70 to 80% of your overall healthcare costs, and better transitions, specifically sort of keeping people away from the emergency department when they don't need to be there, and then making sure when people come out of the hospital on the other side that they don't go back in. And then the 4 tools that we'll use are that coordinator and our nurse practitioners in the clinic and our pharmacists as one tool. Those are the ones that are in our 10,000 locations, because the other thing we bring as part of this chassis is a distributed model so that people can be able to sort of get with us, and we'll talk about that. Then enhanced digital and telemedicine outreach, better monitoring of home activities. We want to own the home, as it were. I'll talk about that in more detail and keep close track of people's biometrics. And then finally, as already noted, connectivity to the provider. So 3 targets, 4 tools. The whole idea here is to try to shrink the distance between the patient's everyday life and their health care. Again, sort of thinking about if you're an active patient, the most you're going to see your doctor is 4 to 6 hours per year. And what we want to do is be engaging, especially sicker patients, in their health care much more frequently than that. So our 5 common chronic diseases: diabetes, hypertension, hyperlipidemia, asthma, COPD, and depression. Everybody would recognize those, but they fit really well with what we're trying to do. First of all, they're very expensive, and any of you in this audience can come up with the same sort of statistics that I look at all the time about how much we'd be able to save if we could just get diabetes under control, and how much hypertension costs the American public in a given year. What better adherence to anti-hyperlipidemic medications would bring about. How we could reduce costs associated with asthma and depression. So all of them are very expensive. This is a good place for us to be sort of targeting. The other thing that's important for us is that all of these diseases these common chronic diseases are treated with simple generic medications, and that's really in our sweet spot. That's in our wheelhouse, as it were, trying to get people who have chronic disease to take generic medications to lower their overall costs and lead better lives. That focus on adherence is what historically we've done as a pharmacy innovation company, and this is presuming that we're going to be moving more heavily into population health management by acquiring an insurance company. But you can see how these fit so well with what we've done sort of historically. And then the third thing is there's clear outcomes, and those outcomes are available on biometric devices that have all gone digital at this point. It's all information that we can follow. So when we're thinking about sort of new engagement for these kinds of chronic diseases, we're thinking about real-time information on how well the patient is doing, real-time information on how well they're taking their medication, and really convenient ability to sort of interact with them, with nurse practitioners and pharmacists. So those are our 5 common chronic diseases, and we've estimated sort of what the savings can be for average clients when we get these kinds of conditions under control, both on the commercial side and on the Medicare side. The second target, as I mentioned, is this fragile patient. And in any one population, you're going to find a very small concentration of individuals that are fragile and that are going to be costing the total number of people in that particular group a lot of money during the given year. These are the people who really need insurance. So I always say the ethical responsibility in insurance is to provide the deepest possible risk pool for individuals like us who are sick. That's why we all have insurance. It's a communal activity we throw in together so that those of us who do end up sick, and we don't know who they're going to be, can get the care they need. But these are the patients that require a certain amount of concentration on the part of those people who are trying to do population health management. And we think we can do that by using much better claims data and also information that's available in electronic medical records, as well as information that could come in from their home, to be able to develop the algorithms to identify those patients who need attention right now. And then we think we can provide that attention. We already have companies like our Quorum company where we have literally thousands of nurses who go into people's homes today, and we would increase that and try to identify those patients who need specific interventions and take those steps well before they end up in the hospital. Because as a physician, and many of you are physicians, you realize when people come into the hospital, simple steps that could have been taken while they were at home might have saved them from coming into the hospital in the first place. So targeting the fragile patient, and then finally, the transitions. So we know that there's a lot of waste in the American healthcare system, and one obvious place of waste is people who go into the emergency department and don't need to be there. At least 25%, in some studies as many as 40% of emergency department visits could be prevented. And we can offer them a place as we begin to sort of expand what we do at our retail clinics, which we call minute clinics, in the direction of urgent care. We feel like we can accomplish 60, 70, 80% of the care that's necessary for somebody who doesn't need to be in the emergency department. And what we do is with digital information available to our patients or call-in nurses, we can direct people to the appropriate place for their care, and as a result of that, avoid an unnecessary visit that's going to cost a lot in a hospital. There's no way you're going into an emergency department and coming out with a bill that's less than $1,000, and that's simply unnecessary waste in many situations. And even greater waste, well illustrated by the Secretary's recent readmission, is people who go into the hospital and then have to go into the hospital, come out, and then have to go back in. Most of them, the majority of them, never see a doctor in between the time they go out of the hospital and they come back in. And the overwhelming majority of them are confused about simple things, and especially their medications. We've done studies where we've demonstrated, published in Health Affairs a couple of years ago, where we have the readmission rate simply by doing a comprehensive medication review. So another thing that sort of falls into our pharmacy wheelhouse is just making sure people, if they come out of the hospital, they drop by CVS, they have a visit with our nurse practitioner, we make sure that they're on the appropriate medications, that all their caregivers are aware of what's going to happen, and that they go home safely and that they stay home so as to avoid those kinds of unnecessary costs. So all this is algorithm driven, it's all focused on specific symptoms, and it's all supported by digital information. So those are the 3 targets. Now, if we just talked about the 4 tools. So the first one is the coordinator, the clinician at the Minute Clinic, and the pharmacist. So if you sort of set this up, we're going to be gathering information, and we do gather information today from electronic medical records, from digital devices, and also from insurance company data, and of course our PBM data. So we're running algorithms at that information all the time, trying to identify gaps in care and risks that those individuals have. So there's this digital intelligence that's coming in, but then we want to have all that information available and coordinated for these individuals that someone can come in and see at our care centers within our CVS pharmacies. And CVS pharmacies, they're good, they're close by, people can get to them, and then they can talk to these providers. And we have really incredibly high satisfaction scores with regard to interactions both with our pharmacists and our nurse practitioners. Our nurse practitioners are consistently at the very top of industry in terms of their net promoter scores. And the kinds of things that they can do at this level of sort of preventive and low-level primary care, and the kind of messaging that we can provide through this digital intelligence to our pharmacists is basically raising the license for both pharmacists and nurse practitioners to be able to deal with these kinds of problems. And then we're adding a whole series of services to the front of our store. We'll be doing more infusion. We've talked about the fact that we're getting into dialysis. We'll have cost transparency tools. We think we're going to have an extensive set of point-of-care lab tests. We're already opening about 100 optometry and 100 audiology centers in the coming years. So you'll see CVS stores being slowly but surely sort of transformed into some place where you're going to feel comfortable, and your loved ones are going to feel comfortable getting their health care. But the thing about us is that we're convenient, and that years of sort of studying behavioral economics has taught me, as well as anybody else I think who pays attention, that the critical thing from the point of view of getting anybody engaged is making sure that it's convenient, that what you're trying to engage them to. And that's what we have to do with healthcare. So we really feel like this is our chassis, is the physical location. But it's going to be enhanced by digital and telemedicine outreach. So we've already seen that by adding different kinds of aspects of digital visits to what we do at CVS, that we can increase engagement considerably. And you will, and many in this audience are going to know better than I, the ability to sort of analyze that data is changing dramatically. I've seen it change dramatically over the course of the last 5 years in terms of the kinds of things that we can get using artificial intelligence-based analytics and assistance. And then we also see telemedicine playing a large role for us and for others in this space in terms of bringing care directly to the home. So you can see how I sort of laid this out. You talk to an artificial intelligence diabetes assistant, that person, that bot that you're talking to, interacts with the patient, and as far as they know in terms of the texting, they're talking to a nurse. We can bring a telemedicine consultation into that, and then refer people to Minute Clinic or other providers when we need to. So we've got the backup of the physical space, but a lot of this can occur digitally. And I did note at the bottom, we're a large Epic customer, and we'll continue to grow that relationship with Epic, and that provides us with the interconnectivity to the rest of the electronic medical records. The other thing we say is that we'd like to own the home. We want to make sure that we're the people who are monitoring patients at home. And I think all of you would agree that there's going to be a lot more information coming in there. And there's at least the promise that we're going to be able to sort of see patients who are fragile getting more fragile by analyzing that information and then intervening. I'd say we're the ones who are interested in doing this. When I talk to my colleagues who are primary care doctors, they've had it. They don't want any more information. They certainly don't want information that's coming in from the home. So all of that information that's coming in and being analyzed with these algorithms has got to go somewhere, and we feel like we can own that relationship. And that certainly goes with regard to the biometrics that we're expecting on these patients with chronic disease. And then I would say with regard to the providers, this is sort of how we see things. So what we'd like to do, we're maintaining a relationship with an integrated delivery system. A patient with a primary care provider, integrated system, has hypertension and diabetes. They send that patient over to us. We look at their biometric information. We do the point-of-care testing, lab testing right there when the patient's there. We can modify the dosages of the medications the patient's on or start them on a new medication. All of this information, everything that we're doing is basically being logged in the electronic medical record, and we're keeping good records so everybody in our enterprise, as well as any doctor we're working with, can see exactly what we're doing. We do that coordination and counseling, and we think that's our sweet spot, that counseling that people are missing out on. They can come and see us much more frequently than they'd be able to see their primary care provider. And then we take that care plan and deliver it back to the primary care doctor. So we see ourselves as complementing, not competing with primary care. Last year at Minute Clinic, we referred about 3.7 million people who did not have a primary care provider to a primary care provider. And we intend to continue to do that, to try to find people a primary care provider, but to also sort of fill the gaps between those primary care providers. And interoperability, I think, I guess I could get in debate, and there's going to be experts coming out, I know, later today on this stage that know a lot more about interoperability. But what I'm seeing is something that's completely different than 3 or 4 years ago in terms of our ability to get information out of other electronic medical records and to transmit that. And we are the biggest transmitter of electronic medical records in the country as well. Last year we exchanged in Epic 7.3 million medical records, and we're set up to go to all of the electronic health records on this, as well as 15 others. So we take interoperability very seriously. And so I think, in the model that we're looking at, we feel like it's a new collaborative model. It's really, if you're an insurer and you know that we have made plans to acquire Aetna in order to get into the insurance business. Of course, that's pending regulatory oversight. But as an insurer, you're thinking about 2 ways to relate to the healthcare system. One is that you could sort of buy up an entire layer of primary care, and you could buy the urgent care, and you could buy surgical centers, and then you could play the hospital sort of one-off of one another, and the specialists as well, and that might be a sort of reasonable way to go. That's not what we want to do. What we want to do is provide basic preventive primary care, and then work closely with integrated systems, make sure that everybody has a medical home, but that we're part of that sort of extended medical home, and that's why we call it complementary primary care, integrating with accountable care organizations and the medical home. We think that the healthcare system needs that kind of connectivity, and that's really what we want to provide. So, in summary, I've tried to sort of give a sense of where we think we're headed, and we're barreling along in this with all aspects of our organization, looking forward to this transformation and making appropriate changes associated with that. But what we want to do is fuse digital engagement with convenient one-on-one care. And we're trying to reduce costs, but we're trying to reduce costs by better quality, better coordinated care. We know as a pharmacy innovation company that if we can get somebody's hemoglobin A1C down, a full point, that we're going to reduce their cost by about $2,000, $2,400. And that individual is leading a better life, and that's really sort of what we intend. We're supporting accountable care organizations and the medical home. The whole infrastructure is sort of equal parts AI-evaluated data and physical space at convenient locations. So that's the chassis that we're aiming for. Let me stop there and thank you very much for your attention.
Thank you, Troy.